All right, this is a really important application that is called fractional flow reserve. And the reason it's important is this test and the number that is obtained from the patient with this test is a quantitative determination of whether this patient should get a stent placed in this lesion or not. And so cardiologists use this test in order to make that decision, as opposed to just basing their decision on the look of the lesion on coronary angiography. As you can imagine, when you're looking at these lesions, you would err on the side of caution, and if a lesion looked kind of tight, you'd say, you know what, it would look a lot better if it was open, and so it could lead to putting in more stents than are necessary. So we would like to just put in stents that are necessary, and this is one way to determine that. You insert a catheter into the coronary artery that has the lesion, and you put the catheter, you can measure the pressure proximal to the lesion on the side that's towards the aorta, and then go beyond the lesion and measure the pressure that is distal to the lesion. And what you do is you then give, while you're doing these measurements, you give the patient a agent that distends all of the smaller vessels such that the demand for blood flow is high. And what that does is when it's at its highest, so when the coronary blood flow should be at its highest, you will measure the highest pressure drop across this lesion. And if that pressure drop, while that you're in this hyperemic state, if that pressure drop should be greater than 20%. So the pressure here versus here, it's 20% lower on this side. If that is true, then that lesion is called significant and you should get a stent. So if that pressure drop is 20% or greater. So the fractional flow reserve number for that is 0.8. And if it's 0.6, then the pressure drop is 40%, etc. This is done in the cath lab quite often, and it gives you the assurance that this lesion is in fact a flow limiting lesion. And there was a really profoundly impactful study that was done in Europe. It was published in 2012. And this was looking at whether or not you should use FFR, or fractional flow reserve, to guide when to put a stent in. And this study at the time, I don't think could have been done in the United States because they based their placement of a stent in a patient entirely based on the FFR. Even if the lesion on coronary angiography looked like a very significant lesion, even if it was 70% stenosis or greater, if the FFR said, don't put that catheter in, then you didn't. And I don't think you could have done that in the States because at the time that was considered, not good medical practice. If you had a significant lesion, you stent it. The interesting conclusion to this whole thing is that with the patients who are stable, so these aren't people who have STEMIs and their ECG is indicating that they have a serious heart attack going on. If they have at least one stenosis with FFR of 0.8, right, or less means greater significance, FFR-guided PCI with drug-eluting stents plus best available medical therapy, compared with medical therapy alone, decrease the rate of urgent revascularization. So these people did not show up back at the hospital with a STEMI. Okay, the people who received the best optical medical therapy came back to the hospital at a higher rate than those that received the stents. So therefore, if you make this measurement and it is below 0.8, you should put a stent in if you want that patient to be in that lower risk group. And this is the last sentence of this paper is fantastic. It has an important result, but it's not the main result. The main result, we just read it. Among patients with stenosis that were not functionally significant, the best available medical therapy alone resulted in an excellent outcome, regardless of the angiographic appearance of the stenosis. So you can be looking at a 90% stenosis on your angiogram. If you do FFR and you get 0.8 or above, so you get 0.9, those patients did just as well with medical therapy as they did putting a stent in. And so this came as a huge surprise at the time. It also, indicated that maybe 50% of stents being put in the United States shouldn't be put in, right? So remember, this is before the ischemia trial where you did this selection, randomization of stent to no stent, and there was no difference. This sort of foreshadowed that result, and they found no difference in this trial. You can see that there are a number of patients here who have an FFR that is quite high. That means that the pressure doesn't drop across that lesion, even when they have these extraordinarily high stenosis on angiography. And so these ones up here, basically, you're saying I got a 90% lesion and my FFR is 0.9. So how does that happen? How does there become no pressure drop across there? Where does the pressure come from distal to the lesion? Perhaps it's collateral flow in that patient. Who knows? But the measurement indicates you shouldn't put a stent in that patient, even though they have this remarkably high lesion, just using appearance. What we can do quantitatively with CT, as opposed to angiography, angiography gets one view at a time. You usually get an orthogonal view just by moving the angiographic device, but we can get it simultaneously. Here's the left main. It's, thinning down to like a 50% stenosis or something back here. And then we can look at it in the orthogonal view, the same stenosis. Here's the width of the vessel proximal to the stenosis and distal. You can see it gets narrow. Draw a blue line through there. So let's look at that lesion perpendicular, and here it is. And you can actually just make a measurement, say, well, this vessel that is normally 2.5 millimeters in diameter has shrunken down to 0.95 millimeters. And so you can construct a physical model of that stenosis. How accurate that physical model is depends on your understanding of how CT determines signal strength, right? So if this half height here is actually the width of that vessel, then you're accurate. It turns out that's not really the case. We've done a lot of studies on looking at what happens when you get a very small cylindrical device or object in a scanner, and it just gets dimmer, right? Globally dimmer. The full width at half max doesn't change. So especially down here at around a millimeter or below. So you have to somehow learn how to read these. And most clinicians who read CTs accurately actually look at the brightness of the vessel to report on the significance of the lesion or the severity of the lesion. You can quantitatively look at the severity of a lesion, and with CT, what is done is you can compute the fractional flow reserve, FFR, with the CT scan without being in a interventional lab where you put basically a pressure wire across the stenosis. So you start with your 3D coronary CT angiogram. You segment out using your favorite segmentation routine, which is usually deep learning these days. And then you look at the amount of myocardium as an indication of how much blood flow is required to go through a vessel. And then you, on a computer model, you dilate these vessels and calculate the maximum flow. And you push that flow through the vessel, and you use computational fluid dynamics to do that. And you measure the velocities and the pressure drops at each point along the vessel. You can then find out that, oh, my pressure dropped down to 0.58 distal to this lesion here. And if I put a catheter in there and measured it, you would hope that we would get an FFR of 0.58. And this is a company does this now. They're called HeartFlow. It's FDA approved. It's now available to all patients, and we do it at UCSD quite often. Here's an example of a minor, there's a lesion here, obviously, there's a stenosis here, but distal to the stenosis, the computational fluid dynamics looks like it's giving us about a 0.9 FFR, and so that is not significant, and you would indicate that you should not do or you should not place a stent across that lesion. And here's the angiographic picture of that lesion here. And you can see it's a 50% stenosis, something like that. But the FFR across that lesion was 0.9. When it was measured with a catheter, it also came up with the same number. So, and as you can imagine, when they were getting FDA approval for this method, they did many such studies where they predicted what the FFR would be in a patient, and then they go to the cath lab, measure the FFR with a catheter. And as you can imagine, when they were getting their answers wrong in the initial phases of this company, they modified their segmentation and their modeling such that they got a closer match. They learned from that data. And fairly soon, my prediction would be that they'll just take this coronary angiography data with CTA, feed it to a deep learning model, and come up with these FFR predictions. Okay, I think we'll stop there and see you next week.